Okay. Hello everyone. Welcome again. This is our second webinar on the series Global Health Insights. Uh, we are very fortunate to have Dr. Katoch as our keynote speaker today. The title of this webinar is Towards a Human Approach to Leprosy Management in India. I will briefly introduce Dr. Katoch's work, and then I will invite him to present, and then I will also briefly introduce our moderator today for the discussion part, Professor Nanta Bhan, and then she will engage in a moderated discussion with your questions. So while Dr. Katoch is presenting, please write down your comments, reflection using the chat option so that Nandita can get all those questions. With this, let me, yes, and then I will invite Professor Rama Baru to share her concluding remarks. So with this, let me introduce our keynote speaker, Dr. Vishwamohan Katoch is former Director General of ICMR, Indian Council of Medical Research. He's a globally respected leader in public and global health research. He has over 4 decades of experience on leprosy, tuberculosis. His work has advanced equitable diagnostics, disease control, and transnational research in low and middle income countries. He was also the founder of the Department of Health Research. We are really lucky to have him for this session. His work spans across various disciplines. He has built actually many multidisciplinary and rural health research platforms and promoted people-centered and human approach to infectious disease management. If you look at his academic work, he has authored more than 325 scientific publications, and he is the fellow of actually all national science academics in India. This is like the highest level of achievement someone can have in the field of science in India. We are really lucky to have you with us, Dr. Katoch. Thank you so much for joining. I would like to request you to go ahead. I will share your presentation.
Thank you.
Yes, sir. So let me share the slides.
Can we go to the second slide, Dr. Abdul, straightaway?
Yes.
Well, actually, first, my greetings to everyone. I'm here today basically because I knew Pasarama. And good morning, Pastor Nandita. Also, I saw you just actually first to see you, but couldn't connect. And thanks, Dr. Abdul, for all correspondence, I think, the interlinking. I saw our old colleague, Dr. Joydeepa, also, because we've been working with her also for, I think, decades, several decades. But there will be many others with whom I might have worked, but I'm not able to see their faces. But that's all right. You know, the question is, when we try to reflect on a topic like this, and there is a old disease, old topic, and a very old story, but we don't know whether anybody has learned any lessons like what happened in the last 20 minutes. I really don't know what happened and how it became okay. I don't know that also, actually. So, you know, many times we try to reflect But usually the past is a history actually. The current today is a challenge, but the past historical part tells you lessons, what went wrong and where you can correct. If you really introspect actually. So, when you look at the global situation of leprosy today, it is, we find that Southeast Asia is among the leading contributor. And the whole globally, also like 2024, we had nearly 1,72,000 cases, and 72% of them were in the Southeast Asia and mostly from India. But this is not the negative part of the picture actually. When you look at the positive side, if you look at a Southeast Asia, now like we have 100,000 patients now, but at that time there were more than 10 million actually. Okay, 60 lakhs were in India alone when the multi-drug campaign began actually. So what we are seeing today, there is a problem, but this is only 1% of what we were 30 years back actually. So 99% is a conquer. We have conquered 99%. So it is a success story actually. So control of leprosy is not a failed story anyway. This is I call it one of the most amazing success stories of the modern medicine. But that's okay. We should reflect on what we have done. But what the trouble is, like today, 72% in Southeast Asia. I said the India is the main contributor, and second is Indonesia, followed by the Bangladesh and these small countries around, Nepal also. Then look at the Africa actually. The six countries in Africa actually. They constitute about 11% of the global burden. About 19,000 cases in six countries. And I'm the editor of I think perhaps the world's oldest leprosy journal, Indian Journal of Leprosy. And we keep on getting publications from Nigeria also today. I mean, in this last issue also, there is a publication from Nigeria. So Nigeria, Tanzania, then the Mozambique, Democratic Republic of Congo, and these are the countries where the number are still persisting. Madagascar, Americas, this is mainly the Brazil. And the Brazil is the second largest after India. Again, a huge country, same type of socio-cultural problems, same diversity, same type of socio-cultural problems. So these three areas, they constitute I think maybe the 97% of the total problem in the world actually. And rest everywhere there is a small numbers. So when you look at it, actually the disability rates, the child rates, on which we were all the time worried and the people suffered because of that, they are coming down. One thing more which has happened in the recent period, we know that actually all the biology people who are there and who have worked with the leprosy, they know that the mycobacterium leprae was the earliest organism to be identified with any infection. And we continue to think that it is the only one. But another one has emerged in the last couple of years, the mycobacterium lepromatosis, which is from Mexico, Brazil, India, Myanmar, Malaysia, Colombia. How much is the epidemiological contribution? I don't know, but it is there. Main issue which I would like to reflect here, the late reporting. The cases with the high bacillary load, disabilities, they continue to be reported in all these countries, not only in India alone. That means there is a problem of the capacity actually, which I'll deal with. Higher proportion in the poor and marginalized section of society. This is again a global, right? When you look at Africa also, DRC, the Congo, that is on that side of the poverty line, and there the same trouble. And all the countries, all the pockets are linked to the poverty actually. So, and in India also, the marginalized communities, for every disease, every problem, they suffer. And the same is the story for leprosy too. So next slide, please, Dr. Abdul. Next slide is about the India's battle. I'll show you the subsequent some slides. India has a long history, modern medicine's history actually, more than 200 years of our fight against leprosy. So India has been again I say the main institution, main country where the science has progressed, and everything. The trouble was also maximum, but the science also has the maximum progression has happened from India only. Our national program is again 70-year-old, and as I said, we have done wonders. up to 2025. But after that, the final battle is proving very tough. Next, please. This is the historical history of the previous one, actually. History of the leprosy in India. I think most of the evidence shows that it originated from India only, but some people, some of the biologists, they think of the Africa also. But maybe at that time the seas were linked actually, because the oldest evidence which we have found from a one fossil which is close to Udaipur, it is a 2000 BC actually, and so it was there for a long time. It is there in the Charak Samhita, it is there in the Sushil Samhita, everywhere in all our scientific books actually. Manu Samhita also deals with it. But that means it is an old historical disease which India had actually for a long time. Even actually just almost the 250 years back, actually, the Hamilton, the one of the Bengal Medical Service the doctor, he described the two forms of leprosy also. So that the clinical leprosy also started getting emerged from this place actually. 1857, the Cholmugra oil was described as a treatment, but again, it went into limbo because of that movement, which we call it a movement of independence. But then ultimately, I think there was a turmoil after that. But after that, the science evolved. The time when the Dr. Hansen described is that the causative organism in Norway, the same type of science was emerging here also in India. Next slide, please. Right in the Berlin conference in 1897, we demonstrated the leprosy organisms in the nose. So that means there's a mode of spread. This again one of the very early papers. So whatever the global changes happening across in Europe, the science was started emerging, building up as a modern science in Europe. But at the same time, the things were happening in India too, actually. And most of the work was by the missionary doctors. They came with the mission, but they were highly qualified, competent people. So they described the disease, they described actually the treatments, and the Cholmugra oil. That this is a very historically we started getting used here in the modern medicine also. This is again by Roger and Muir actually. But I said right in 1857 we were using it actually. So that about 50, 60, 70 years people didn't get the benefit. Then the Belra, I think has contributed immensely. Our own legendary people like Dr. Dharmendra actually, right in 36 paper in 1941, he described the lepromin antigen also. The immunology, even immunology of the science was emerging here actually. Then Dr. Robert Cochrane and these people working in the Ekpat Leprosy Home in Mumbai, they did wonderful science. But I think main change happened because of with the Mahatma Gandhi actually, his interest. Because he was the one person who could bring everybody together actually. So he brought the missionaries, Indians, everybody together actually. And he started himself writing on it in the young India. So that made the science actually modern actually. So that I think that made the modern leprosy, I think in India, I think I'll really, the main credit goes to father of our nation actually, Mahatma Gandhi. After that, the story continued, the associations grew, and the surgery also in the CMC Bellore, I think it started by Paul Brand, is again a historical milestone. So I think all achievements, all actually the links, the evolution have been from the West, for the science has been from the India, mainly from India. Next, please. But important transforming moments which change the whole thing. When you're talking of the 99% success, this all happened with this multi-drug treatment actually. This was empirically designed 3-drug combination. They thought add one, because the one was not working, the second was also was not working, so they combined everything, and it worked actually. So this 82, the multi-drug treatment designed by the WHO expert group, that proved a game changer actually, whole entire world. But then actually we started evolving. See, right from our institution in Agra itself, we came out with this we didn't call it uniform, we call it a common regimen. 6 months for the possible ciliary disease with the limited, and for the extensive disease 12 months. So this all initially came from the India, but then they did the global trials. Chemoprophylaxis, of course, it was not a Indian origin, but it came here. And then, but this again a vaccine, the MAPE vaccine, mycobacterium W, ICRC, they're all from the Indian ones. The BCG was, of course, from the abroad. Surgically, huge number of methods. I'll say more than 80% surgical methods have been described in India, whether by the with the missionary surgeons or by the Indian surgeons. And there's a history, all right, from the Nashirantia to Dr. Palande to Srinivasan. And I mean, we started with Dr. Paul Brand, Frichi. I mean, this is a people, there no religion, color to it. Actually, the people were from everywhere they invented. So they all came from India. Socio-behavioral intervention, which I think all of you will be aware, particularly Dr. Rama has been very active in this for several decades. Many of them were thought of in India, tried on a pilot scale, but they didn't get the, that fillip of, they never became a part of the, I think, socio-cultural change, because that needs a push of a different kind, actually. Some drive, some leader who will be pushing that, and that really goes to the background. That's the transforming moment, I'll say. Next, please. This is, you look at it, I think, and this is where I'm showing you this actually when you were talking of the humane approach today, you'll have to think of some very dramatic issues actually. Like prevalence of the disease, right? We have figures from 1941 onwards actually. Again, Dr. Dharmendra was the main key player at that time. But, we keep on looking at up to 91, this numbers kept on increasing. The prevalence kept on increasing. Even the drugs had come earlier before that. The program had come before that. And then in 2005, we reached that magic figure with a massive success here. And after that, this is stagnating. There is a improving, now improvement seen, but you imagine the 0.3 per 10,000 change we have been able to bring out only in 20 years actually. So something I'll comment on that. And when you do the actual survey, this survey was led to, this is a countrywide survey called by Parliament. My wife, she led it actually, and the entire country, what the main picture was that the figures were 3 times more by actual survey. But it's not the fault of the healthcare system. Their data was 100% accurate. There was no fudging of the data. The people don't come actually. So that means they don't, at that time, it doesn't bother them actually till the nerves start getting damaged, till the disability starts getting there. So it is the main issue, the social issue is at the community level actually. The people, because there's innocuous one patch, they don't care on it, they keep on working. So by the time it becomes the extensive one, then they come to the report to the system. Drug resistance, it was very big, but with the multi-drug treatment campaign, this came down actually. It's almost done actually. There's hardly anything, very little problem left. Disabilities again, 20 to 25% in the pre-multi-drug treatment era. This came down to very low actually now. This is but still, this is not acceptable. It may be down, but I don't think anybody will say that it can be accepted actually, because it should not be there actually. It can be prevented by and large. Next, please. This is the general picture which everybody shows. This is how it came steep like this, and then it has been like this actually. But now it is a slight decline after that. Yes. So to sum up, these experiences from 1955 to 1990, we started the program here. There are a huge number of clinicians, professionals who knew the work, and they're very eminent social scientists also at that time. Only one I see one surviving, but of Dr. Mutatkar from that era, but all other are gone. But they were very prominent people on both the medical side, surgical side, and the social side, everywhere. But the disease still, the tools were not perfect. That means the drug could contain it, but it could not cure actually. Now we have the drugs which can cure actually. So this 15 years was the most dramatic one. This whatever the success we call about, 98% success we call about, this happened in 15 years only. So massive campaign led by the government and the very backed by the NGOs. The TLMA is one of them, Lepra Society, the GLRA, Damien, American Leprosy Mission, all the people they contributed. And so their support to the government system, their network, plus the massive program led by the government, I think that led to this success in 15 years only. But we started at 60 lakh, 62 lakhs actually. So more than 6 million cases when the program began. And you could bring it down to almost nil actually. It's 100,000, 200,000. Now it's less than 100,000 also across the country. But again, when this vertical program got merged actually, this is something which is important from the social angle, because we thought this is a small number. It can be handled by the general health system. We have not succeeded at that. That strategy was not correct, because the networks became weaker, and the expertise became weaker. The doctors were not knowing anything, the competing priorities. So that I think led to the stagnation, and I think led to the very slow progress in the last 20 years. So I think we have to really think about the that means somehow the as a people who can push, we should still push for the I think the massive campaigns which are underway, but I think they should be taken more frequently. Next, please. So when you look at the general scenario, India and other endemic countries, since 2005, the situation is mostly stagnating, very slow in decrease. And the worst part, which I told to you, was the low endemic states when the number becomes very low. It is very bad. That doctors not able to pick up, people don't care. Most people come with their disabilities, and that's very painful, very sad actually. With a disease which is easily treatable. So I think this is low endemic situation which we have already moved to. It is something to be handled with a very critical care, very I think with the power and the energy, and I think in a very different approach of a mass communication, which I think very critical at that stage. You need the diagnostic tools. People have even abandoned the slit smears for it actually, which is something that was very easy to do. They thought no need to do it. The surgical access to surgical care, referral chain, they're very weak actually. I must tell one thing: the social scenario of social integration has vastly improved actually. Few new, I think, people getting rehabilitated. Few leprosy colonies left. So many discriminatory laws have been repealed. See, I remember, when we joined Agra, and my wife, she is a clinician. She at one time headed the hospital and that institution also. There, they every month she was just some woman was rehabilitated, and mostly one or two. So when 20-25 people were thrown out in the North India, I'm talking about that. Huge, the OPDs were full because the deformities were at the peak actually. And then men, usually the women don't throw out the men. That's a very rare, the ratio was only say 9-1. Okay. So ultimately, maybe the mindset, whatever the social compulsions, mostly I think that the bent of mind of the woman, she wouldn't like to break the home. So I think that was but ultimately in next 20 years, so I'm talking 78, 80, when the therapies came, the effective treatments came, new regimens came. By last 20-25 years, there's hardly any rehabilitated actually. Nobody, I mean, so otherwise she was coming to Jaipur, to other places to find a shelter for them. There were the shelters in Agra were full, so there will be no places for them to keep them. So I think that somehow in the North India, we see a very clear change. In our time when we were there, I was there up to 2008, and she was there up 13. But I think by that time, that people getting thrown out, that have become almost nil actually in the North. But I think that is a positive side. But still, I don't say that has happened everywhere. The people report the many things in the other places. So the socio-cultural reaction of the people, they're not uniform. But at least in the North India, that changed. Actually, I've seen that. Yes. Next, please. Dr. Abdul, next. Yes. Then, people are one more issue which is coming, which is a very important one. And this is again an issue which, which is of interest to entire group here. You're dealing with it. The mental health issues in leprosy are getting flagged now. People were suffering all through the history actually. But I think this was not ignored actually. Some compassionate people did care, but it is not to be studied as a science. But now we find a number of publications coming from the right from the Kashmir to the south, and from outside the country also. I find the publications. People are looking at the mental health aspects of the people actually, how they are suffering, what they are suffering, what type of the disorder they have. So and they have this depression, anxiety, and many other disorders, mental health disorders, which they are what 2 to 3 times more than the common general public actually. So they keep on suffering inside it. Issues regarding the urban leprosy, people publish, people few publications on the stigma reduction. I think this is some areas of interest, where people are publishing actually. Next. So coming to the main issue, when we this towards the humane approach, this is the title, this wording came from Pastor Rama. This was not my wording. She said, "Okay, what will you talk about?" I said, I was suggesting somebody, I'll talk about the whole leprosy. But then she said, because her your professional, your social commitment, your mental thing, it goes to that actually. And I think that's the goal of everybody, but it doesn't come. So when you look at that, when you look at the health actually, it is a physical side. We have been looking at the physical side. I told the mental side was getting ignored actually. Social well-being was attended, but the issues were complex actually. So there were the attention is case to case basis. It is not for a total transformation. So something we do in one area, then we stop it. We publish something, we do something, we go to the second. So they have never become the drives. They have never become a drive of their community or society as such actually, except for a few places, localized places. So I think when you want to achieve the health, actually, the physical, mental, social well-being, they are adding even the spiritual one also, but the spiritual is a part of the mental one. So I think that becomes that's something we have to ensure that we have to target total actually. The second issue is this is the 10 parts of the Alameda Declaration. The second one is the existing gross inequalities. That means that disparities, and they are seen in almost every disease, but they are very acute in terms of the leprosy also. So there, even the stigma was too extreme actually. So people were getting affected adversely actually, significantly. Next, please. Now coming to the India, we want the health services to be equitable, everybody, and India is also signatory to this Almaty Declaration actually. Our constitution has the commitment for the same. And last British Health Commissioner, which people normally don't like to give the examples of our British rulers, but he was Indian, Sir Joseph Bohr, 1902 batch ICS officer, one of the brightest bureaucrats this country had. And his Bohr committee is a guiding principle even today, actually. So he was the last health commissioner of British India. He belonged to Nashik, but I think that his entire service was during British period. So I think this report actually is like, even today it is relevant 80 years later also. It tells the way it was analyzed, the way it was beautifully done. He talks of inequalities also. And I think he was a man with a very strong socialistic mindset actually. So wherever I've read his speeches, they were all looked at that actually. So inequalities to him also were not acceptable. He was always looking at that. His report also covered on the leprosy also. So, they established what type of facility should be set up. There's a one full half page on that. And even this our central CLTRA Chengalpattu, this became a national institution because of his recommendations. And when we became independent, the first Indian cabinet under Pandit Nehru that accepted this report actually, implemented this report. This entire public health system, PSC, CSS, All India Institute, CLTRA, they are all emanated from his recommendations. So ultimately, this was on the radar at that time also. Then we have tried to improve the access. We kept by the National Rural Health Mission, National Urban Health Mission, Universal Health Coverage, Ayushman Bharat. We have tried actually, but we know that because they are the other priorities overtake. That's the issue actually. The leprosy, we thought we have successful in it. I think reducing the number. So we become complacent about it. So the last phase is mainly the phase of the complacence actually. Next, please. So when you look at the key issues today, when I think I've given you the historical background of the problem, our evolution, global issues. I think yes, all living beings they deserve human treatment. I'm saying that all living beings. I'm not saying that only the humans demand. The animals, plants. Why we should kill everybody? I mean, I don't want to even kill the bacteria also, because if they are in the environment, they are not doing anything. They are living actually. From there, the life is emerging. So many benefits in our body also from the bacteria actually. So why you should kill them? So point is, until unless they turn pathogens. So only you shoot a terrorist. You don't shoot a common person actually. So that the idea is there should be no discrimination. But I think there's no discrimination in leprosy as far as the healthcare workers are concerned. They don't discriminate. Problem is the leprosy affected people get ignored, as other emergent senior serious problems get the priority. जैसे पैच वाला है कोई नहीं आ जाना यार यू कम आफ्टर फ्यू मंथ्स यू कम सो आज टेस्ट हो गया ये टेस्ट नहीं हुआ come after some time. First, he or she is herself is ignoring the patch actually, and when they go to a health facility, then there is doesn't look like a priority. Something with a acute respiratory failure, acute cardiac problem. He or she is a priority actually. So, this integrated setup, I think, becomes a handicap for them. While it is a good towards the merger actually, but because we want the people to be integrated, we don't want a stigma, we don't want the leprosy people to be treated separately. So this is a positive step, but becomes discriminatory when actually implemented actually. So I think what you need here actually that means these services we should ensure the service actually. Let it be an integrated setup because it is economical. Everything we don't dispute the government's those thinking from that angle. But at the same time, the person he or she should get a proper or child should get a proper care actually. That's it. So the issue is within this system, how you can ensure that the dedicated time, dedicated the priority is given. You don't get ignored, so your disease doesn't get ignored. Your social issues don't get ignored. So I think the issue is, I think that humane treatment within the system. Then the second part is, the other disabilities are. So they also had the stigma. But when people start learning about them, this is due to this gene, this is due to this thing. So then, the people stop blaming you. So that sin theory doesn't like this, not your sin actually. It is a chance actually. So it is whether it is infectious or non-infectious, you don't worry. I mean, a polio person today doesn't get that same actually, the stigma actually. I think that's the issue of looking at the stigma, the disabilities, the disability causing neurological problems, disability causing other issues, they should be dealt with in a very, I think, in a very holistic manner. People, they should be cross-teaching actually. What issues they face and how do you handle that? So I think the lessons learned from one disease can be transformed to the other one actually. I think that's my message in there actually. Because leprosy was a dreaded disease due to, I think this is disabilities only. So if disabilities are gone, and we saw that change happening. I said during the Agra actually, the several thousand patients used to come for treatment actually, and they were all disabled in that time. Some nasal deformities, so some the nose deformed, face deformed, eyes, your actually the hands, feet, everything, But when their number went down, that I think that the stigma had automatically went down actually. See the leading figures like Mahatma Gandhi, we all know his role. Many missionaries, like Father Damien, Father Muller worked in the Mangalore only. Other side, Baba Amte, Manor Devan, Patwardhan, Jagdishan, no, they tried to break the cycle actually. So I think they tried to bring the social reforms. It did work actually, but it worked in those areas only. That social transformation somehow I think didn't spread out. What Gandhiji used to lead the kind of those countrywide or global campaigns. I think that has not happened actually. Nobody took it at that level actually, and these people are all gone. And I really don't know. There will be a leader who will take it up as one of the themes, like what the Prime Minister did for the Swachhata Abhiyan. You need somebody at that level leading that social change, because social change will be, I think, will come from the top only. We have to keep on creating the examples, but those examples are to be carried forward by somebody. Stigma has gone down, I told you, but the self-stigma is a major problem. And that national survey of this, I talked about that, which in our entire country, my wife did actually, that it brought out, total stigma was very low actually, but the self-stigma was persisting. So people who have suffered, they themselves had a problem. So they because some of the earlier social thinking, cultural values, they get into the brain. So others may not discriminate you, but inside you start keep on thinking there's some problem. You can keep on hiding, you keep on delaying, you keep on believing that it's not there. So I think the self denial that all continues to a larger extent actually. Now our National Leprosy Eradication Program, I say it's a success story. Strategy changed from vertical to horizontal. So that's competing priorities I talked about. The issue is now focuses on numbers actually. We talk on numbers all the time. For every disease, we don't talk of numbers. We don't talk of the humans. We don't talk of their suffering. We don't talk of their issues actually. So diagnosis, medical management, but the social and mental issues have been ignored actually. For all, nothing I'm saying this is not as peculiar to leprosy, but here it damages in a slightly bigger way actually. Next, please. See this, I think, very poignant picture, which I think all of us have seen. Mahatma Gandhi nursing Acharya Pratyur Shastri, who was a great success scholar, and Gandhiji used to do this actually in Sevagram, where the Gandhi Memorial Leprosy Foundation came. And this I think his example, same was done by Father Damien, Father Muller, everybody, these people, and all Baba Amti, and all that they have done that. They followed those traditions. But I think this picture is always a very historically important picture, which you need not worry actually. And Gandhiji had done it. And you look at his Young India paper. He was not a fool actually. He had done it. He had seen the data that is a disease of very low infectivity. So more than the compassion, he was driven by there's nothing to worry about. So he gave the message. He was not reckless to recommend to somebody else actually that you do like this. He knew this is a disease with a very low infectivity. So you should not be unduly worried about it. So, and then you should have a compassion, that you should have the same humane feeling, same kindness to any sufferer. So I think this is one of the very poignant picture which I think we have seen since our childhood, and it was there all the time. Next, please. So when you look at what you need to do actually, see the first part is priority is that health systems are to be strengthened. The question is access. And I told you that access became weaker when we merged the national program from 2005 from the vertical to the horizontal one, because there is a competing priorities and other people didn't have the capacity to handle it actually. So that I think, and that's how 99% success in 15 years, but only only little drop in next 20 years. So that is because you didn't catch the people. So that communication with the people was lost actually to a large extent. So I think that improving the access, strengthening the health systems is the key actually. So that means we have to focus as for the time comes. We have to focus on them. And then the stigma reduction, that effort should continue. Prevention strategies, they are there. I'll mention them. If you use them, then the containment, I think, is eradication will be much faster. And it can be done. There's nothing wrong about the strategy part. Next, please. See, even for diagnosis, actually, no, 99% of the disease went down by the conventional wisdom, clinical wisdom. The clinicians and even the paramedical worker who were trained at that time, they could accurately diagnose. They didn't require any technique actually. Very small number you required pathology, very small number you required the smears actually. Smears did help actually. So you used to slit smear and make slide and see it actually. So the very simple technique. But now in the new context, when the doctor's competence has really dwindled, and they are now is a different world. They're different, and they are actually with the AI they will be virtually robots only. So the question is, that the science is gone. So you need the test more and more. And then there is a disease which is some cases which are atypical, which are difficult to diagnose in the beginning. And if you treat them at that time, and many of them will self-heal also. But why you should take a risk actually? Even if one number, I say one person also counts. In the last meeting when we were there, and Dr. Joydeepa highlighted that point. We see that one even to us, the one person also counts. Why there should be one person with disability also? Why? There's no reason. We should prevent that actually. Try to prevent that. So there, no case should be misdiagnosed. We are moving to a number. When the more than 6 million, we are only few thousand left actually. So they should get the best treatment actually. They should be diagnosed in time, and they should be confirmed. So these molecular diagnostics should be these techniques which are there already. And some new platform will come, which again the TLM and MolBio they are partnering. This is a molecular technique which reaches right the periphery actually. And there, this is a platform, one machine, which with by 30 type of test can be done. Change the chip, do the assay. We use the same machine for tuberculosis, we use for the COVID also. So, and this is even the slit smear and the smear person in the periphery, that means high school person is able to do that molecular test very ably. The more than 2,000 machines are there for TB itself. So I think this kind of a platform should be available to the leprosy also. So this will be a strategic decision only. So as soon as this test comes into the public this domain, commercially available to everybody, they should be available actually. So why even dermatologist is confused or a doctor is confused? Why they should be confused actually? This test should be available to everywhere. It's available to tuberculosis. Why is not available to leprosy actually? It should be there. So I think this is the goal. This is the kind of scenario we have to look at, from the social angle, that leprosy also has to be part of the scenario. It is not to be thrown out. This is over. No, I don't. I think, and let that money be spent by somebody, by the government actually. The governments have plenty of money. They're not short of money actually. Yes, please. This is that platform I was talking about. It's an Indian system developed by engineers from the Bangalore. And this and for tuberculosis at one stage, this proved to be the best actually. In 2018, when we did even the comparison in the Africa everywhere, it was better than the gene expert, when the best and the best actually of that time. Now they have improved it. Maybe the competition is tough even now, but it's still doing well actually. And it is for 30 diseases actually. Just change the chip and do the assay, and everywhere. So that's I want to show you this slide. This is a pride of very national pride also, and we feel very happy that we could be among the best. Next, please. And this will be available for leprosy also. The pathology actually. So most of the pathologists, they do the pathology well, but atypical cases, they need a combination of the molecular test and the pathology. This is something a slide one of my colleagues actually. He was a dermatologist, and he was interested in the molecular pathology. So in my lab, he did it. This is a slide of 2004 actually, but hardly anybody will be using few places, because for even for pathologists, it's not an attractive disease actually. So I think the question was that such a system had to be ensured actually, that medical college systems somewhere you have the dedicated places where the people are able to diagnose leprosy also with the same precision. Next, please, if needed. I think I'm still insist on the clinical one, but if needed. For the prevention side, this is the chemoprophylaxis, where you give the drug and that kills. So this is used for many drugs. The drug which is used for treatment, the same you use for the chemoprophylaxis also. And this is recommended globally also, tried also. But drug works only when the bacteria multiplies that day. And it multiplies once in 13 days, once in 12 days. So it will kill only those which are killed, which when they are multiplying on that day when you give the drug. And so it doesn't go more than 50% anyway. But we have an Indian vaccine actually. And this is a very cost-effective vaccine. And this vaccine protects up to 10 years actually. So where the disease is persisting, you should have both actually. So I think we have the tools, and using the tools, we can achieve the best actually. So I think we want to prevent, you should prevent to the best actually. Next, please. But this it was all a individual rivalry and a politics, which doesn't let the technology reach the people. That's the trouble actually. Next, please. And somehow that is I think at the peak in India. Next is the surgical care actually. So, some of the leprosy cases do require surgery. The disabilities are there, or some during the course of the treatment management, they require the nerve decompression. But the access is dried up. See, in 50s, 60s, 70s, or even when that time we joined leprosy in 78, it was dominated by surgeons, very eminent surgeons. Now there's hardly anybody left actually. See, if you think of the whole country, we don't even the 3 or 4 names come into mind which consistently do it. Service might be offered by more, but who doing the science also around it, they're less than a half a dozen actually. So I think that access has to be improved. Actually, that's something the government can do, because that they have to ensure, they have to see that it gets on the agenda. Improving ulcer care, again, is an important problem. And the people who will suffer once, they'll keep on having recurrences because of the anatomical changes in the nerves and the organs which they go there. So I think they have to be handled. So that means you have to be repeatedly looking at the improving the ulcer care in a very consistent way. And more of it is a retraining of the healthcare workers across and the people there, I think, which is the key one. The care after cure, this is a government gives a due importance to it, disability prevention and medical rehabilitation. But the point is, somehow, again, the infrastructure is missing. Who will do it? Who will provide it? They give in the money also for it. But I think, except for the NGO sector, there are hardly any surgeons left, actually. They will in the TLM circle, they will be one or two in a Shivananda in Hyderabad, Kari Kari, and I think but Jabalpur, and that's all. That's it. So the country is vacant, actually. This is, I think, very tragic story of the commercialization of the medicine today. But I think it is essentially a social issue and a political issue, but it has to be handled that way. Yes. See, this is a environmental problem because it's a link to the environment. The environmental health, this bacteria survives in the environment, and studies abroad in India have shown that it can persist. And in the countries, we have done the careful studies. This is linked to the housing, the damp housing, the moisture. Particularly Indonesian studies are excellent, actually. They have proven it, actually. So I think, if you want to give the health education, the environmental health again has to be part of it. And I think when Swachh Bharat Abhiyan should be expanded to your housing, sanitation. It picks up, but it should look at that, actually. So I think in our future teachings, because disease will not vanish overnight, actually. Once it is environmentally can be a source, then it will keep on be a trigger there for long years. So I in that context, as a part of the teaching, environmental health and aspect should be kept in focus. You should not forget what you look at the case, and treat and over. It won't be over. So I think we must look at that. Next, please. Now to manage it, it is a notifiable disease, and we have the very efficient e-health, m-health platforms. Number of the telehealth platforms also have come up. Their skin apps, their apps to AI-based tools to, teach, train, even the cases who may never have seen a case. Like, when we passed out in 74, we completed MBBS in 74. Our final MBBS, it was a must to give a case of leprosy. But after that, it was thought, it's no longer required for everybody. So it is a specialized disease to be handled by specialists, actually. And so that's gone. So you need to train a huge number of people in the periphery, actually. So and again, this has to be part of the training for future also, because even small numbers, handling them, I think, in a timely manner, appropriately, is one of the top priorities. So I think AI-based solutions for teaching, training, I think teleconsultation, I think that has a huge scope there, which again has to be part of our, I think, policy thinking, and I think the science and the teaching, implementation, everything. Next, please. So this is the dream, This is a national strategic plan that we 2027 we want the India to be free. That means a zero transmission so that means everything stopped. We want a zero infection, zero disability, zero stigma. This is quite a big goal. The global goal is 2030. But our people were more enthusiastic, so they convinced the Prime Minister to make it 2027. So it's only 2 years left, and hopefully they'll reach somewhere. But it's a very tall order, because as I said, that the problem is with the competence of the system. So that means they diffuse, and you need a large number of trained people. Earlier, they were dedicated people. And how can you really cover everybody? Next, please. If you look at that, so the tools, as I said, the knowledge and the tools exist. We don't know what is it, how to diagnose it, we know it. If which technique will improve the diagnosis, whether a molecular one, bacteriological or pathology or combined, that we also know. Whether you use the ultrasound for imaging of the nerves, what to do with it, and how to improve your its acumen or diagnosis, that we also know. But the question is access. So in a competing scenario, I think that the issue is, can we be sure of the proposed timelines? But forget about it. Even keeping a goal, we would have moved towards that, and we are moving. I'm telling you, even after we kept the goal, yes, the things have been improving. So certainly, when you try to chase something, you reach somewhere. So I think I'm not negative about it. But 2027 will become perhaps 28, 29, or 30. We don't know that part, but it's okay. Zero disability, zero transmission is achievable, but very intense efforts are required. Next, please. So in 2005, we reached that goal of 1 in 10,000. I said, magic figure, that's a big number. So I think we celebrated, and rightly we celebrated. I think nobody thought in the world we can do it. We did it. We have a mass campaigns, like LCDC, EPSL. These are the acronyms for the campaigns, like some are ASHA-based, some of the limited campaigns. So I was recommending that they should be more often. There should be more and more campaigns, but they have a targeted way of doing them. So they are covering. So if we assume, like they say, by 2027, we will reach everybody. If they say they really reach, and all the contexts are also given, chemoprophylaxis plus immunoprophylaxis. Chemoprophylaxis alone will not work. It goes only up to 50% maximum because it kills the bacteria which are multiplying that day. So I think there is very limited effect. But if they do both actually, then you think you have targeted all. Again, you need, the outcome will be known 10 years later because the incubation period is long. Then the people who are already disabled, who have the problems, they need a care for their life actually. So even at 2047, you need a care for the people, leprosy affected people actually. So I think it is not a touch and go. It is not a number game. We have to now think of that truly humanized approach actually when you're looking at the person's difficulty. So single person counts, So I think that last TLMI's thing was, I also came back with that message that even single person counts. So that means right from the medical treatment and beyond. Leprosy affected person should be, I think they should get that personalized care. It is not difficult at all. I believe, we should attempt that for everybody. I mean, whether it is whether the government does it or doesn't do it, but at least as a citizens, we must stress on that. We must work towards that wherever we can there. Our healthcare, whether you do with a government, government, private combined, it should look at everybody, And I think that approach, we should look at a person's suffering as a priority rather than the symptoms alone, that means the disease alone. So I think the physical, mental, social well-being, those two words, mental and social well-being, should not be ignored as the time moves now actually. But in this entire game, something depends on the government. And government is not insensitive, I tell you, because it is only way of who pushes for it and who drive the policy. Policies again, driven by professionals only. So that means the professionals, associations have a bigger role. The NGOs have a bigger role. Even when the government institutions became weaker in leprosy care, earlier there were a lot of government institutions. They certainly became weaker and weaker in the leprosy research also, leprosy care also. Except for, I think, 2 or 3 places left now. The other side, the government's contributions in science academics have become very weak actually. But the TLMI continued with the same push. And they kept the torch on, and they got the support also. It's not that they got the funding from the competing funding from the government agencies like ICMR everywhere. So ultimately, the torch has to be kept on, somebody. NGOs have a responsibility, and they have the opportunity, and they have the motivation. They have that mental feeling also. So I think these are the motivated people that through the NGO sector, I think they have a big role to play for years to come. Then individuals, professional associations have a second one because they will shape the opinion of the government also. In a competing priorities, their number will become less and less. So that we know, understand that actually. So when the number becomes less and less, I think from the policymakers' point of view, I think the push will be weaker and weaker. So we have to be working with everybody to, I think, keep that torch alive, and push through the political system. And I think that system still works, and political system is sensitive and is not a that politicians. I think I still because in my career, I mean I read them to be the best actually. So they ultimately my ranking is very different on the individuals. And in end of my career, I ranked the politicians to be the best, followed by bureaucrats, and then I put everybody lower down. But anyway, many will not agree with me, but I think my perception has been from that perspective that the anything which benefits the people, they catch, but they should be writing, pushing that change to them. Last slide I will come. I think this is a slide I show for the since I retired, 2015 onwards. Dr. Kalam, I think he motivated everybody, and all my talks I've been showing this that you dream it, back it up with hard work, observation, diligence, and I think anything is achievable. He said many things, and Dr. Kalam's, I think he remains one of those inspiring figures for our country. But this I think his message always echoes in my heart. So the our goal of that humanized approach, that means a care which is a person centric now, because it won't be a public health centric anyway. I tell you, by 2027, 2028, or maybe 2030, number will be really very low. But even in that situation, to keep the attention and focus on leprosy, that means every case gets the care, and either they are prevented, so they get that means they get both the prophylaxis, then they're trained in a way, or their conditions improve in a way. So I think preventive parts are also pushed, but then the early diagnosis, management, if something goes wrong, so that means keeping the awareness about in the public, awareness in the doctors and the other professionals, and then actually see a system which is sensitive to their needs, sensitive to the needs of a single person also. I think that has to be the goal. So I think the journey is a long one. It is not going to wish away, but it is a doable. Thank you very much. Thank you.
Thank you, Dr. Katoch. I will stop sharing and then. Yes.
Thank you.
Thank you so much. Thank you so much, sir. I coordinated a course on disability in both in my previous workplace in Vrije University Amsterdam and also here in this university. I genuinely feel that if I had the opportunity to listen to you before doing those courses, my student would have been much more benefited. Thank you so much
Thank you.
for
Thank you.
sharing
Thank
these
you.
insights. Especially India's experience. You brought the historical background, India's contribution. This is really fascinating. I will incorporate some of this in my teaching. Thank you for doing this.
Thank you.
Now I will invite Professor Nanita Bhan. She is a professor and vice dean of academic affairs at Zindal School of Public Health and Human Development. She is also the main person behind this idea that we should do monthly global health insights webinar. We started this program, MSc Global Health and Human Development, last year. So far, we have 55 students from more than 15 countries across the globe. I genuinely feel that many of the students, not only from India, from other countries, they will really get benefit from these insights from India. I request Professor Van to moderate the question answer session. We have already got few reflections and questions.
Thank
Nandita,
you so
please.
much, Abdul, and really, what a pleasure to hear you, Dr. Katoch. I feel very intimidated having to moderate this session, but thank you so much. I think for showing us the importance of taking historical lessons from leprosy that are very much applicable to many other diseases, both infectious and chronic. And I think the success story, as you said, of leprosy is only possible because of the engagement of health systems, programs, social change, and the sort of mission mode with which historically in India and outside people have taken up the cause of elimination of leprosy. And looking at these sort of intersections have made the success story possible, but we recognize that it's not gone and it's still prevalent in many countries. I know we have many questions, and I have my own questions actually. So I'll take the liberty as the moderator to ask my own first question, particularly from the perspective of global health. I think you had talked about, and we know from data that you still see cases in India, Brazil, Indonesia. And as you sort of pointed out, even in other contexts, you are seeing papers come up in your journal. So I wanted to understand, are there any, when you see global data on leprosy, do you see any distinct patterns between these countries? Are there other things that sort of come up as being specific to one context versus another? So that's sort of my first question.
Dr. Bhan, the question, you see the global pattern is only thing. Why in few places this has remained, and that there, this is that decision making basically. India, we decided prematurely to merge it with the national program, the general health programs, and that has happened in the countries like actually the Brazil also. So wherever the disease has persisted is basically they were winning the battle, they prematurely announced the victory actually. So I think that is a very common pattern everywhere, and they thought the remaining problem will wish away. It doesn't go away that way actually. And the second part is, wherever the poverty will be there, the access to these services will be there. I think you need a very dedicated attention to problems like leprosy. Yes, I think that's the common lesson everywhere. There no pattern as such, but the common key element is the marginalized people are more affected, and wherever the governments the attention was diluted, so it has persisted. But it is a global success, but then the last phase has become difficult in some places. That's all.
So you're saying that obviously poverty and inequalities have an important role, and particularly in looking at the way the last remaining cases are turning out in many of these countries. From my own sort of work, I work primarily on gender, and I know that there is a lot of research within leprosy and in other fields as well, where there is this sort of complex role of looking at gender within women as caregivers, but also women as patients are often abandoned, and there is a lot of stigma and aspects related to that. I think one of our colleagues on the course has also actually very beautifully written about a Bengali film where the woman is abandoned by her family, and these are sort of the heartbreaking sort of moments. So I wondered if you could speak to, like, in your experience over the decades, how have you seen some of these issues play out, and is there any hope?
See the gender issue was important in the leprosy also, and the woman when they got the disease, as I gave you the example of that late 70s and early 80s of our own institution Agra, when I gave example of my wife also. As a clinician, she was facing that every month there were one or two women thrown out by the people. So they have to find a place for them. So the women were at the receiving end anyway. So I think they have them. So that except when they became the rehabilitation, they were the main sufferers actually. So I think as a caregiver, I don't think they had the main role to play every time they were playing, even today also. But they were at the receiving end at that time. See, when the question was that two people are there, you see both of them as a danger to you. So whom you see a bigger danger? So they thought, let's throw the woman out. So ultimately, why they tolerated the men within the society? Men tolerating men, women tolerating men within the society. They were not thrown. So I think their rehabilitation was, they were main sufferers. But eventually, what happens is that after the disease became with the low disabilities, the disabilities went down. So that stereotype, I think that general stigma, overall stigma started getting diluted. Everybody benefited. That neither we in that place we were finding either the men or the woman. Nobody was thrown out actually. So I think the rehabilitation became a less important issue. Yes.
So what has led to, as you say, over time, the reduction in stigma? Like, have there been campaigns, social behavior change? You talked
See,
about a lot of laws enforcing,
yeah.
Anti-discriminatory practices. So what
Yeah.
has really led to that reduction, which is great, of course, but
I think, Dr. Bhan, my view is actually, my perception is, I say I don't, is view and perception is basically. It is basically the people how they perceive actually. When the disabilities went down, the fear went down. It's a stigma is because of the fear actually. So that, that image of the beggars on the street, that image of the people, with the disabilities, I think that it was basically fear actually. I tell you, you're scared of yourself. Same thing was happening in terms of when you have the COVID came also. Same, this is a very recent one example. So you were scared actually. So you were trying to, but some brave people come forward and they help everybody, but others don't actually. So you're scared basically. Yes.
I'm going to ask one more question before I
But
also.
other means, but you said the other the laws
Yes,
getting on
you
the compulsive
mentioned that.
side, they
Yes.
do play a part actually, because laws were used by people to settle the scores. Say for example, you get a disease, so they want to get your land, they'll find a way to throw you out. So, and if you want a divorce, you use that law to get a divorce. So that, laws being misused by people to settle scores within the family and outside the family, I think that also played a part. Would have helped many people. Yes.
Okay. I'll ask one quick more question before I also take some of the questions that have come. I think you had mentioned that, and I think this was very moving for me when I read a little more about this, and also spoke with Rama before this call. I think the question of pediatric leprosy, like you said, that the cases among children have gone down, but I was reading that there's still a significant number. So what can actually help us eliminate those remaining sort of cases and sort of move on to that, as you said, 2030, 27, whichever year, but what can help us reduce these cases now, like especially pediatric leprosy?
Dr. Wan, the pediatric leprosy should have gone much earlier out, because it was a target. I think we didn't sincerely follow it up. See, the mass campaigns to diagnose the disease in children should have been the first priority. It has been done in the surveys. It has been done, but not everywhere. So that means it's covering all schools, covering everybody. I think that should have been the priority and should be priority even today. And when you do the prevention part, I think it will benefit everybody. Yes.
No, certainly, and I feel like, and there is an important emotional appeal to
Yes.
this issue, particularly
No child should suffer. No
no
child should
child
be.
should suffer.
Yeah, yeah,
Exactly.
yeah,
So
yeah,
I very
yeah,
strongly believe that
yeah,
should be the priority focus.
yeah.
Okay, let me read a few questions if you don't mind. So we have a question from Vasundhara Nair, and she's saying that in my PhD, I focused on social determinants of health to understand barriers and facilitators in health systems for infections. Was wondering if a similar prototype would work for developing interventions for chronic leprosy as well. So, sir, any thoughts on that?
Well, what exactly she wants to say, actually? Yeah.
I think she's saying that she's read about social determinants of health and interventions around social determinants of health for reductions in infection. So I think what she wants to know is, are there any interventions related to reduction in social inequalities or in systems, social systems, families, communities,
I think,
community-based interventions?
this is the
Yeah.
most ignored part of our society, actually.
Sir? Oops. Dr. Katoch?
Maybe we lost the link.
I think he'll come back. Just let's give him half a minute. Meanwhile, I mean, I know he's not listening, but I think we have some fabulous questions. I'm sorry I sort of took on my own questions, but there's another question around looking at caste. Oh, Dr. Katoch is back. Thank you. Thank you for being back. Sir, you're on mute. Yes, please.
See, the social inequities, they are major problem, and they will continue to be a major problem. I think we say many things, but we don't make any efforts to, remove them. Only, if we improve the access to the health services, that itself will be very big. But other part will persist, actually. Yes.
So there is another excellent question from an attendee and that is about looking at caste and the proportion of cases among scheduled caste communities within India has increased sharply. The official explanation seems to be that case finding is improving, but the increase in case numbers is happening over a long time. So what do you think, sir, is happening? Scheduled tribe community, sorry.
Yeah, no, I think it's again, difficult to comment because nobody has systematically studied them. It is only you look at the numbers. So the government, those explanation that they are more getting detected more. Maybe the massive campaigns are in those populations, but it's really not true. I'm telling you, many places like Bihar, Jharkhand, Odisha, yes, those numbers have been persisting for a long time actually. So that means they're actually the nutrition, the housing, those, the way they are living, those conditions are not improving, not changing actually. And I presume that would be happening even for TB also, that would be happening for others also. Because in the tuberculosis also, the number of the TB cases in the marginalized communities have been 3 to 4 times higher than the others actually. So I think basically I think it is the way their housing, with their nutrition, that is affecting everything. Yes.
The social determinants and the sort of social fault lines. I
Yes.
think you're very aptly...
And Dr. Nandita, basically I'm telling you, the hygiene is very critical, I tell you. These bacteria persist in the outside in the system. See how your house should be simple, sunny, but the sun rays should reach inside actually. So it should be dry. So I think the more their design of the houses, I think we're not giving adequate attention to that actually. Yes.
No, I 100% agree, and I think that is the sort of last battle.
Because Dr. Nandita, disease went down in the Europe and many countries even without a treatment actually. So one was that was not a humane way, they isolated the people. Okay? But the second was the hygiene actually. With that hygiene, all diseases went down, all infections went down actually. So I think that they're focusing on the hygiene and the living conditions. That means the type of housing, everything. That's very important. Yes.
I think these are the social determinants that perhaps Vasundhara was also referring to.
Yes.
So we have one more question from Dr. Madhav Dhawan. He's he's also on the course and he's actually a practicing doctor. So he's saying, sir, compared to other affected countries, what would you recommend as the best practices that we can change or implement for better management of leprosy medically and social norms to maybe integrate them more, and mental issues. So I think he's talking about what are some perhaps best practices for implementation.
See, the best practices, I don't think we have any examples to take from anywhere else, actually. We have to improvise of what we need to do here. We need to retrain our doctors. So that means they pick up early. Then secondly, we create this, this chain of the laboratories which are already existing actually. So those laboratories, those chains has to be augmented. So wherever there is a confusion, they are able to access the lab for the confirmation. So I think, and then I follow it up. That's it. I think the only thing we have to reorient our clinical acumen, clinical actually there was expertise, and we strengthen that. I think that's the core, nothing else. Yes.
Okay.
Because our problem is the implementation only. In the last phase, it is only question of access, only one word.
Right.
No issue.
It's the last mile in a sense. I'll say
Yes,
just
yes.
one more quick comment that has come in. I
Yes.
want to perhaps reflect on that. And this is something we work a lot on, as our school does, is looking at, someone has said that there is a need to emphasize the One Health approach in leprosy. So what would you say about that? I think as a school, we work a lot on looking at
Yes.
planetary health and looking at
Yes,
issues.
yes.
So,
Dr. Nita, I've already emphasized that. And I really emphasize the One Health approach only because the last part will be your housing and the way you live. So the housing and nutrition, that means the environment actually. There are no evidence of any animals being the sources actually, except for the armadillos in those some few countries. The rest actually it doesn't multiply. I mean, little multiplication has been shown in a few animals, but not significant. They are not epidemiologically relevant. So I think the main issue is perhaps your living condition. I'm telling you, and we have to focus on that because that is the mycobacterium leprae shown to be surviving there for months together in those environments, and it is epidemiologically linked to the transmission. So I think that's the only thing which has to focus. So the environmental health is very critical, but we say the general environment and hygiene. These are only two issues. That's all. Yes.
Thank you so much, sir. I know that we have sort of overshot our time, so maybe
Yes.
Abdul, if you,
So that's
and
why
back to maybe.
that's why I was getting call.
I'm so sorry, sir. Like
no,
I know that it's such
nothing,
a master
nothing.
class. We sort of lost our, lost track of time. It's
Yes.
been such a pleasure. I'm going to hand back to Abdul.
Thank you.
Thank you so much, Nanita and Dr. Katoch. My apologies for the first part of this technical glitch, but this session went really well. Now, I would like to request Professor Rama Baru to share her concluding reflection. Professor Baru is a full professor here in the Jindal School of Public Health and Human Development. In MSc Global Health and Human Development Program, she is going to teach a full course on globalization of health and healthcare. She has a long career in academia. She taught in Jawaharlal University for 30 years. And she is also a honorary fellow with the Science Institute of Science Studies. She's also honorary professor at India Studies Center at the Central China Normal University. Professor Rama, if you could kindly share your.
Thank you, Abdul. Thank you, Nandita. And what can I say, Dr. Katoch? Thank you so much for accepting this invitation. And I want to say that it was very important, and I when I spoke to you to give this lecture, because this is a course on global health from the South. And I think it's very clear from the way you presented the entire presentation clearly shows how it is a problem of the global South. Leprosy as a disease. I think what was fascinating about your lecture was the history of growth of science of leprosy in India and the kind of contribution that India made to the understanding of the disease, the science of it, and the implementation part of it was extremely fascinating. The other very important aspect was the multidisciplinary. So clearly you, and I now understand, Dr. Katoch, why you as DG ICMR actually promoted a collaboration between Indian Council of Medical Research and the Indian Council of Social Science Research. Today it was very clear to me that it is really the experience of leprosy, the science of leprosy, the kind of collaborations that happened in the global south across countries, and how egos were not the defining feature. Because, you know, Dr. Mutatkar, whom you mentioned, was a medical anthropologist. And he was very much part of this team of building a whole generation of anthropologists who, with international collaborations, to work on the issue of leprosy. I also really appreciate that point you made about how this lecture also opens up our own imaginations for cross learnings across diseases and to bring in the lived experience of disability. When you say put the human, the individual who's suffering at the center and to reach every person, you are really bringing in what is very, very important for us, that even if diseases decline from a public health perspective, the suffering doesn't go away for that one person who's still afflicted. And I think you brought that out very beautifully. And maybe there are lots of lessons that we can learn on the importance of collaboration, cooperation between sciences, social sciences, epidemiology, and very important aspect that you brought in was also of the lab sciences. I love the way you said, we have the TrueNet, which we used for tuberculosis. Why aren't we then creating a platform for comprehensive testing of leprosy and maybe other diseases that I'm not an expert there, but there are many new emerging infectious diseases. Could those platforms be used? And a very, very important aspect, and I want to end with this, is this tension between verticality and horizontal programming. And, you know, in a lot of our earlier work, we always critique the vertical programming. But I know, having learned from the Chinese, they always said, don't look at it as either or. Look at where and until when do you need vertical programming, and when can you transit to horizontal, and what are the capacities that are required for horizontal system. When you move to horizontal, what kind of systems you require for building. I especially in the end want to thank the Leprosy Mission Trust of India, which in a sense sensitized me as both a researcher and a social scientist to this question of leprosy. And Joydeepa is here, and we have been co-collaborators for so many years, Dr. Katoch. Their network truly, truly requires, exemplary clinical work and a humane approach to treatment of leprosy. In fact, their latest project is looking at healing in leprosy. And I think healing is the word that goes much beyond curing. And thank you so much. Sorry we've extended your time, but it has been riveting to hear you again. Thank you so much.
Thank you, Professor Rama.
Thank you, everyone.
Now,
Thank you.
so we are having our next webinar on next month, February 8th. Yes, February 8th, Sunday in the afternoon from 5 to 6:30. And for that one, we have Professor Manjari Mahajan from New School in the Newark. Her keynote will be on reimagining multilateralism in global health. That is also a very appropriate topic considering the current situation in the global health. So I invite every one of you to join. We will share the link and everything, and we'll publicize. But thank you so much for all your participation, especially Dr. Katos and all our participants, our moderator, and also Professor Baru. I look forward to all of your participation and enthusiasm in the upcoming sessions as well. Thank you.